Imagine going to a clinic for, like, a highly sensitive pelvic procedure.
Okay.
And one doctor tells you that you can resume normal intimacy in, let's say, exactly 4 hours.
Right. Super quick.
Right. But then another doctor, looking at a very similar procedure, bans you from using a tampon for an entire month.
A whole month.
Yeah, it's crazy. Why is the medical world treating the exact same anatomy with such wildly different rules?
I mean, it sounds completely arbitrary from the outside, doesn't it?
Totally.
Like they're just, I don't know, pulling numbers out of a hat. But the reality is actually far more intricate.
How so?
Well, we're looking at a landscape of recovery that shifts dramatically, depending on what is actually happening at the cellular level.
Welcome to this deep dive. Today, we are taking a massive stack of clinical guidelines, post-op instructions, and medical literature surrounding pelvic and vaginal injections, and we are just breaking them down for you.
Yeah, we've got a lot of ground to cover.
We really do. We're talking about everything from nerve blocks and Botox to the O-shot and the G-shot, and our mission today is to answer one highly specific, incredibly practical question.
The one that everyone wants to know.
Exactly. What is the exact post-procedure rest window? Meaning, like, how long do you actually have to refrain from penetrative sex or using tampons?
Right.
And more importantly, what is physically and biologically happening to protect those procedure sites during that time?
Because, I mean, if you look at the source material we've gathered for you today, the discrepancy is just staggering.
It really is.
Yeah. Depending on the clinic you walk into, the needle they use, or the energy device applied, your life could be completely uninterrupted, or you could be facing a massive lifestyle adjustment.
Okay, let's unpack this. We need to decode the why behind the waiting.
Right.
And to do that, let's start with the shortest turnarounds.
That makes sense.
Yeah, we have a set of procedures here where the medical intervention is mostly about physical structure or just temporary anesthetics.
Just kind of getting in and out.
Exactly. I want to start here because it gives us a baseline for what pelvic rest actually means, before we get into the heavy biological healing windows. So let's talk about the G-shot.
That is a great starting point, actually. So the G-shot involves injecting a hyaluronic acid filler directly into the anterior vaginal wall.
Okay.
And the clinical objective here is to increase the size and sensitivity of the area that's believed to correspond to the G-spot.
Hold on, hyaluronic acid. Isn't that like the exact same stuff dermatologists use to plump up lips and cheeks?
It is the exact same underlying chemistry, yes.
Really?
Yeah, it's basically a sugar molecule that binds to water, creating this gel-like volume.
Okay, so because it's a relatively standard temporary filler, you would think the recovery guidelines would be universal, right?
You'd think so.
But looking at our sources, the discrepancy is just massive. Like, we have a clinic in Miami that explicitly states you only need to wait 4 hours before having sex.
4 hours.
Just 4 hours. But then I'm looking at Dr. Ali's clinic, and they recommend waiting 24 to 48 hours to allow for initial healing.
Right, a bit more cautious.
And it doesn't stop there?
No, the parameters get even wider.
Yeah.
The Uruguay Clinic in Switzerland advises their patients that tampons should be completely avoided for a full week,
Wow.
and that sex, sports, and even taking a bath should be avoided for 1 to 2 weeks.
We go from 4 hours in Miami to 2 weeks in Switzerland for the exact same procedure.
Yeah, quite the jump.
I mean, is this like telling someone to wait for wet cement to dry, where some contractors are just, way more paranoid than others?
Well, what's fascinating here is that your wet cement analogy is actually incredibly accurate.
Oh, really?
Yeah, but we need to look at how that cement interacts with human tissue. When you're dealing with fillers, the primary goal of the short rest window is physical stabilization.
Okay.
You've just injected this very pliable, gel-like substance into a highly dynamic, muscular and vascular area of the body.
And I imagine the pelvic floor moves a lot more than your cheekbones do.
Constantly. I mean, it's always in motion. So you want to make sure that filler integrates with the surrounding tissue matrix.
Right.
It needs to bind with the local water molecules and actually settle into the tissue pockets.
Got it.
If you introduce intense friction, pressure, or a foreign object like a tampon before it has a chance to set, that filler can literally migrate out of place.
Oh, no.
Yeah, it gets pushed right away from the target zone.
So the clinics advising a longer wait time are just being extra cautious about the structural integrity of the filler?
Exactly.
They just don't want you flattening out the very volume you just paid all this money to create.
Precisely. But there is a second equally important biological reason for that initial 4 to 24-hour window.
Okay, what's that?
It has to do with the numbing agents.
Ah.
These procedures almost always use local anesthesia, like lidocaine, to minimize discomfort during the actual injection.
Right, because nobody wants to feel that.
Absolutely not. But that anesthesia needs time to completely wash out of the local tissue. If a patient resumes penetrative sex or inserts a tampon while the vaginal wall is still totally numb, they're essentially flying blind.
Oh, wow. Because they could be causing micro tears or injuring the tissue, and their brain wouldn't even register the pain signals?
Yes.
You can't protect what you can't
Yeah,
feel.
exactly. You really can. And we see that exact same logic applied to another procedure in our stack with a relatively short rest window,
Which one is that?
the pudendal nerve block.
Okay, let's talk about that because the pudendal nerve sounds incredibly important. It's like the main pelvic nerve, right?
It is the superhighway of the pelvis.
The superhighway.
Yeah, it supplies sensation to the perineum, the vulva, the clitoris, and it controls the sphincter muscles.
Wow.
So when that nerve becomes damaged, irritated, or structurally trapped,
Mm.
which is a condition called pudendal neuralgia, it creates this chronic, severe, and often just debilitating pain loop in the lower pelvic canal.
And a nerve block is basically an injection right around that nerve bundle to break that loop, right?
Exactly.
Now, according to the guidelines from the University of Iowa Healthcare, after a pudendal nerve block, patients are told absolutely no tampons, no sex, and no douching for 24 hours.
Right.
You can supposedly resume normal activity the next day. But wait, I'm looking at the University of Iowa notes here, and it says the original pain might actually come rushing back within 8 to 10 hours.
Yeah, that does happen.
If the whole point of this shot is pain relief, why is the patient suddenly in agony again on day one?
That is a brilliant question. And it all comes down to the cocktail in the syringe.
Okay.
The injection usually contains two distinct medications. A fast-acting local anesthetic, like bupivacaine, and a slow-acting corticosteroid.
So they do different things at different speeds.
Right. The local anesthetic floods the nerve and provides almost immediate, profound relief. It essentially proves to the doctor that they hit the right spot.
Ah, a diagnostic tool.
Basically. But, as you pointed out, it wears off quickly, usually in that 8 to 10 hour window.
So the numbness fades. The original nerve irritation is still there, and the pain comes flooding back. That sounds incredibly frustrating for the patient.
It is so frustrating. They're basically in this tense waiting game because the steroid, which is the drug that actually reduces the underlying inflammation around the nerve, it takes 2 to 3 days to actually kick in and start doing its job.
Oh, which perfectly explains the 24-hour pelvic rest rule.
Exactly.
The doctors are giving the physical injection site time to close, preventing infection from anything entering the canal. But more importantly, they're ensuring the patient has full, unnumbed sensation back before introducing any friction or foreign objects.
Yes, it is entirely about protecting the patient during that highly vulnerable transition period.
That makes so much sense.
Right. You have an 8-hour window where the tissue is numb, followed by a window where the pain returns before the steroid finally takes over. You do not want a patient trying to use a tampon or attempting intercourse when their sensory feedback loop is completely compromised.
Definitely not. So waiting for a physical filler to settle or for an anesthetic to wear off, that makes total sense. But what happens when the treatment isn't just, a physical substance sitting there?
Right.
What if the treatment actively hijacks your cells? Do the same physical rules apply? Let's move into our second category of treatments, the biological healers.
This is where the post-procedure rules become much more strict, and the physiological reasons behind them become just, well, fascinating.
Because we're moving away from physical stuff.
Exactly. We're moving away from passive stabilization and into active cellular manipulation.
Okay, let's look at the O shot. Unlike the G shot, which uses a synthetic filler, the O shot uses PRP, or platelet-rich plasma. The clinic draws your own blood, spins it down in a centrifuge to isolate the plasma and growth factors, and injects it back into the pelvic floor and clitoral area.
Yeah, using your body's own resources.
Right. The goal is to stimulate new blood vessel formation and tissue regeneration. But the rest window here is very specific. Clinics like Dr. Sharon Lai's practice and the Peak Performance Clinic in Frisco, Texas, are incredibly strict. No tampons, no sex, and no bathtubs or pools for a full 3 days.
3 days of complete pelvic rest. And the reason for this goes far beyond just letting the needle pricks heal.
I want to dig into that, but first, there is a massive red flag in these instructions that I have to point out.
Oh.
Yeah. Along with that 3-day ban on penetration, patients are given a very strict mandate. You absolutely must avoid NSAIDs.
Ah, yes. the NSA ban.
No ibuprofen, no Advil, no aspirin, no Lev for 5 full days after the procedure. I just want to pause here because if I'm the patient, I just got multiple injections in a highly sensitive area. I am sore, I am uncomfortable, and you are telling me I have to just sit there and suffer through it without reaching for a basic Advil.
It sounds harsh, I know.
It is a massive ask. Why the ban?
Well, if we connect this to the bigger picture, it all comes down to how platelet-rich plasma actually works. NSAIDs are non-steroidal anti-inflammatory drugs.
Right.
Their entire chemical purpose is to hunt down and stop inflammation in your body. But platelet-rich plasma doesn't just survive an inflammatory response. I mean, it requires it.
Wait, so by taking an Advil, you are basically shutting down the exact biological process you just paid thousands of dollars to start.
Precisely. Think of the concentrated platelets we just injected, like, well, microscopic piñatas.
Piatas, I love that.
Right. When they are introduced into the tissue, the mechanical injury of the needle tells those piñatas to break open. It's a process called degranulation. When they burst open, they spill concentrated growth factors everywhere. This localized tissue injury triggers a severe localized inflammatory response.
But we usually think of inflammation as bad, like we ice our joints to stop it.
Generally, yes. But in regenerative medicine, that acute inflammation is the biological distress signal.
Ah.
It acts like a flare gun going off in the pelvic floor, telling the body to send in stem cells, increase blood flow, and build brand new collagen and blood vessels.
Wow.
If you take an NSAID on day 2, you throw a bucket of water on that inflammatory fire, you prematurely extinguish the signal, and you severely blunt the regenerative effects of the O shot.
That is incredible. So the 3 days of no tampons or sex is to prevent physical disruption and bacterial infection while the tissue is actively inflamed and swollen.
Exactly.
And the 5-day NSAI ban is to protect the delicate cellular signaling that actually builds the new tissue.
I've got it. The downtime is actively working for you. And we see a similarly extended rest window when we look at vaginal Botox, but for completely different neurological reasons.
Right, Botox. We usually think of it for smoothing out forehead wrinkles, right?
Seriously, yeah.
But according to our sources, it is heavily used for a condition called vaginismus. My understanding is this is a condition where the pelvic floor muscles involuntarily spasm and contract, making penetration incredibly painful or even physically impossible.
It is a deeply distressing involuntary reflex condition. Medical-grade botulinum toxin is injected directly into those hyperactive pelvic floor muscles to literally force them to relax.
Okay.
This breaks the spasm cycle and allows for sexual re-education, often with the help of vaginal dilators and specialized pelvic floor physical therapy.
But the waiting period before you can start that physical therapy or attempt to use a tampon is surprisingly long.
Yes, it is.
The Pain Spa Clinic advises waiting 48 to 72 hours. La Vie Medical Center in California pushes it to 3 to 5 days.
Right.
And the People's Aesthetic Clinic says to avoid any vaginal penetration or tampons for a full 7 days. Why the massive delay? I mean, it's just a needle poke. Shouldn't the muscle be relaxed immediately?
That is actually a super common misconception. Botulinum toxin does not work instantly.
Really?
Yeah, the 3 to 7 day wait has almost nothing to do with the physical needle tract's healing. It is the exact biological time it takes for the neurotoxin to actually do its job.
How does it work? What is happening during those 7 days?
Well, when the toxin is injected, it has to be taken up by the nerve terminals in the pelvic floor.
Okay.
Once inside, it binds to the nerve endings and actively blocks the release of a neurotransmitter called acetylcholine.
Oh, wow.
Basically, it snips the chemical phone line between the nerve and the muscle, so the muscle never gets the message to spasm in the first place.
Okay, so if a patient tries to use a tampon or attempts intercourse on day 2, that chemical phone line hasn't been cut yet.
Correct. The therapeutic effect just hasn't happened. The muscle is still fully spastic.
Yikes.
If a patient attempts penetration too early, they will likely experience the exact same severe pain they had before the injection.
And worse, experiencing that pain could just reinforce the chronic pain loop.
Exactly. And the psychological anxiety associated with it, you really have to wait for that neurological reset to complete before you challenge the muscle.
That completely reframes the instructions. The wait time isn't a penalty. It is literally the biological processing time required for the medication to alter your nervous system.
Yes.
Okay, so we've covered the quick turnarounds for physical stabilization and the medium windows for cellular and neurological resets.
Right.
Now we finally scale up to the longest rest windows in our source material. These are the structural interventions.
This is where we leave the realm of fine needles and enter the territory of intense tissue remodeling, ablation, and surgical alteration.
The heavy hitters.
Exactly. The rules here are absolute, and the stakes are much, much higher.
For example, vaginal rejuvenation. Clinics use lasers or radiofrequency wands to essentially cause controlled thermal damage to the vaginal walls, which stimulates dense new collagen production.
Right.
A clinic in Sugar Land, Texas, recommends absolutely no tampons for a full 4 weeks.
4 weeks.
Then you have the leak procedure, which uses a heated wire loop to physically slice away abnormal, potentially precancerous cells from the cervix. Newton Wellesley Hospital requires 2 to 3 weeks of absolutely nothing in the vagina.
Nothing at all.
No sex, no tampons, no douching, until a doctor physically examines you and confirms it is safe.
And we also have procedures like endometrial ablation or the Assure procedure, which is a form of permanent birth control where coils are inserted into the fallopian tubes.
Right.
Dr. Nodars's post-op instructions are incredibly rigid. Strict pelvic rest, meaning nothing in the vagina until all bleeding and spotting is completely stopped, which routinely takes weeks.
Here is where I want to look at the practical reality of this for the listener, because what does this all actually mean for the patient?
It's a lot to manage.
It really is. If you are banned from using a tampon for 4 weeks, that mathematically guarantees that this recovery window is going to overlap with a menstrual cycle.
No, most certainly.
You are being told you have to manage a period without your standard sanitary products, relying only on external pads. That requires a significant lifestyle adjustment just to protect the procedure site. Why is the timeline so drastic?
I know it is a major adjustment, but the physiological stakes just demand it. When you are dealing with a LEEP procedure, laser rejuvenation, or endometrial ablation, the tissue isn't just being pricked.
Oh.
It is being deeply altered, burned, or physically excised. The cervix and the vaginal walls are left raw, weeping, and highly, highly vulnerable.
So the body's natural defense mechanisms are basically gone.
Exactly. You have to understand the mucosal barrier. The mucosal lining of the vagina and cervix is your body's primary, formidable defense against bacteria.
Okay.
It's like having bouncers at the front door of a club. When you do a LEEP procedure, you are literally burning away the bouncers in the front door.
Oh, wow. What a visual.
Right. Until that new mucosal lining forms, any bacteria introduced into that environment can just walk right past the velvet rope, bypass the cervix, and travel straight up into the uterus.
Which brings us to the danger of tampons in this specific scenario. Because a tampon isn't sterile, and it just sits there absorbing blood.
It acts as a localized reservoir for bacteria.
Ugh.
Yeah. And penetrative sex can physically push that bacteria even higher into the reproductive tract. If bacteria gets into a raw, healing cervix that has no mucosal barrier, it can lead to severe pelvic inflammatory disease, or PID.
That sounds really bad.
It is. This is a massive, systemic infection of the reproductive organs that can cause permanent scarring, chronic pain, or even infertility.
That is terrifying.
It really is.
It makes a 4-week ban on tampons seem entirely reasonable when the alternative is a systemic pelvic infection.
Exactly. When the deep structural architecture of the tissue is actively rebuilding, you have to eliminate any possible vector for infection. It takes weeks for the body to lay down a new cellular foundation and restore that protective mucosal layer.
So to summarize what we have unpacked for you today, the rules around tampons and sex after these procedures might seem wildly inconsistent from the outside. But they are absolutely not arbitrary punishments handed down by doctors. They are direct reflections of the specific biological mechanism of the procedure you just had.
Exactly. If you are told to wait 4 to 24 hours, like with the G-shot or a nerve block, you are waiting for physical stabilization.
Right.
You're letting a filler integrate with local tissue, and you're waiting for local anesthesia to wear off so you don't blindly injure numb tissue.
And if you are told to wait 3 to 7 days, like with the O-shot or Botox, you are waiting for a cellular or neurological process to complete.
Yes.
You are giving the platelet-rich plasma time to trigger that vital inflammatory fire without NSAID interference, or you're giving the botulinum toxin the exact biological time it needs to sever the chemical phone lines and reset spastic muscles.
And if you were told to wait up to a month, like with a LEEP procedure or vaginal rejuvenation, you're waiting for structural defense.
The bouncer's coming back to the club.
Exactly. You're preventing life-threatening infections by keeping foreign objects out of the reproductive tract, while deeply altered, burned mucosal barriers slowly reconstruct their defenses.
The logic is always there, and the precision is actually incredible. The precision is just happening at a microscopic cellular level rather than something you can see on an X-ray.
It is entirely logical, even if the timeline feels, incredibly frustrating to the patient going through it.
And speaking of that frustration, that actually leads us to a final thought we want to leave you with. A new angle to ponder that really builds on all these sources we've discussed today. We've talked extensively about the physical healing mechanisms, the cells, the nerves. But what about the psychological reality for the patient?
Which, in many ways, is the most complex part of the entire recovery process.
Definitely. Think about it from the listener's perspective. If a patient is already seeking these highly specific, deeply intimate treatments to overcome chronic pelvic pain, severe vaginismus, or sexual dysfunction, they're already carrying a massive emotional load.
A huge burden, yeah.
Yeah. What is the psychological impact of being put on mandatory pelvic rest for weeks at a time? Does this temporary ban on intimacy and standard sanitary products create a brand new layer of anxiety?
That's very possible.
Does it make a patient feel more isolated, struggling to connect with a body that feels like it's constantly under construction?
This raises such an important question, because for some patients, that strict restriction might feel like a severe setback, a forced pause that causes stress in a relationship or heightens their bodily dysphoria. But for others, it might be the exact opposite.
Right. Could this mandatory rest actually offer a much-needed, doctor-mandated mental break? Think about the pressure of sexual performance when you suffer from pelvic pain. A 4-week ban means a period where the patient is officially relieved of all expectations while their body heals.
Wow, yes.
They can just exist knowing that the do not enter sign is backed by absolute, undeniable medical science.
It reframes the rest window entirely. It's not just a physical stabilization period. It can be a deeply profound psychological stabilization period as well. It gives the mind time to reset right alongside the body.
It's a fascinating dynamic between our biology and our mental health. So the next time you hear a confusing medical timeline, remember there is always a blueprint. You just have to know whether you are waiting for the wet cement to dry, the inflammation to peak, or the bouncers to get back to the front door of the club. Thanks for joining us on this deep dive.